Hello, everyone. This is Sherry with the CGH Health Foundation. Welcome to our Growing Healthier program. This educational series is sponsored by the CGH Health Foundation, and all of our programs are offered and presented here on Facebook Live. But if you miss one, you can find it here on Facebook or on our YouTube channel. So look for any of our old programs there. In our Growing Healthier programs, we educate you about important health topics, and it also gives you an opportunity to introduce some of our very knowledgeable providers to you, and today is no exception. September is National Polycystic Ovarian Syndrome Month, and we have a newer provider to us in the OBGYN department. That's Dr. Anna Beta-Duden, but she is not new to her profession. And so I'm really looking forward to hearing her talk to Dr. Bird about polycystic ovarian syndrome, or PCOS as it's called for short. Next month, our program is on October 19th, and our presenters are from the cancer department, our women's health department. Laura Leal, who is our cancer navigator, breast cancer navigator, and Charisse Jeziolowski. So put that one on your calendar too, and come back and watch that for us. Women's health is an important focus of the CGH Health Foundation, and we have an event coming up that helps to fund our mammograms and free gynecological services that we provide through our women's health program. The Delicious Designs virtual auction kicks off on October 19th. The bidding will be open, and that's your opportunity to bid on some really wonderful baskets and delicious desserts and help us to fund the work that we do. And so now that I have covered all that, I'm going to go ahead and turn it over to Dr. Bird and his interview with Dr. Beta-Duden.
Thanks, Sherry. Appreciate it. Yeah, so this month is Polycystic Ovarian Syndrome Month, and I got a hold of Dr. Anna Beta-Duden, and she said, "Sure, why not? Let's have an interview about this." So, with no further ado, let's get Dr. Beta-Duden on here. Hi, Dr. Beta-Duden.
Well, hello. How are you? I don't think it
good.
was that simple. You saying me, let's do it, and me saying yes. It was sort of a little bit more of an arm twist.
Oh no! I think it was. You were up for it all the time. You really wanted to. It just took a little bit of persuasion. So anyhow, glad to have you. So I thought Sherry was interesting. She said you've been around for a while. I don't know what she was trying to say by that, but I think just that you're very experienced as a physician, right?
Yeah, and old, yes.
Me too. All right, so let's talk about. We're going to abbreviate this going forward for our interview. We're going to call it PCOS. All right. So for our folks that are listening, that's what polycystic ovarian syndrome's acronym is. So, what causes PCOS?
Well, I don't think we know. It's really, there is no one cause that we can identify. So it's not genetic as far as we know. There is no gene we can test for. There is no environmental substance or cause that we can identify. Some of it comes from another disorder, which is insulin resistance, and that will add to problems with increasing testosterone, which is one of the hallmarks of PCOS.
Yeah. How would you define PCOS? Like when you're seeing.
Well, PCOS is a syndrome, so it has different characteristics that add to the diagnosis, and there is 3 different, I guess, organizations that then have their own different diagnosis criteria. They kind of overlap, but one of them is NIH, the National Institute of Health. And then there's, I have to read the name because I always try to say it differently, but it's Rotterdam Consensus, and then Estrogenic Access Society. So all of them include in their criteria the increased testosterone level, which is the hyperandrogenism. All of them include something to do with menstrual cycles, like an ovulation or normal bleeding or heavy menstruation. And only one of them requires to have the polycystic ovaries itself, like diagnosed by ultrasound with the specific way the ovaries look on ultrasound.
Okay. How do you, when you see a patient that you know is concerning for that, what do you typically do in terms of a workup for them?
Well, first of all, you take their history, like any other visit you would do, and then you elicit history of their cycles. You know, when they started having them, how often do they get them? Do they get them at all? If they're heavy, if they're sporadic.
Yeah.
And then any history of abnormal hair growth that sort of appeared, or acne that's not able to be controlled with some other medications. So those are the things. And then physical exam itself. When you look at the pattern of hair growth, there's increased facial hair, chest hair, abdominal hair, and upper thigh. Is there any other skin changes? Some of them can be like darkened blotches of skin. And then the other things like weight, the patient's weight, blood pressure, and other parameters. Okay, so the next step would be doing some blood work. So there are different reasons for abnormal periods, right? So we'll check patient's thyroid, make sure that that's not contributing to it. If it's somebody who is very young, then we look for kind of genetic diseases that can cause hyperestrogenism, meaning like increased testosterone. We do check the testosterone levels. We check for the carrier of the testosterone in the blood, the globulin, and kind of go from there.
Okay. So like I'm hearing from you that like a patient symptom-wise would have periods would be a kind of either not having them or irregular or heavy.
Yep. Mm-hmm.
Hair growth that's more than you would anticipate.
Yes, you would expect, yes. Mm-hmm.
Yeah. What other kind of symptoms might they have again?
Acne that's not responding to something that the dermatologist is giving, or it's more than just like regular acne. Okay. Very oily skin. Some less common would be maybe hair loss if the testosterone is really elevated. Skin changes, like a kind of darker blotches of skin in different patterns. So,
would ladies have any pain associated with this?
The only pain you would have with this if there was a cyst formation on the ovary, and maybe the pain would be from that. Otherwise, no pain really.
Okay. Okay. So is there any advantage for women to be diagnosed with this earlier rather than later?
Well, I mean, it's the consequences of PCOS can be more than just not having periods, right? So from my point as a gynecologist and obstetrician, one thing is the infertility we worry about in those patients, but also the patients who have constantly irregular menses, at some point they can develop endometrial hyperplasia, like the overgrowth of the lining of the uterus, and then that can cause like very heavy periods because the endometrium has to slough off at some point. And then if it's prolonged and ongoing for years, it can cause a endometrial hyperplasia and then lead to endometrial cancer. So that's one of the things. Other thing with PCOS is if they have the insulin resistance, they can develop diabetes. They can have patients can have abnormal lipid profiles. So that leads to heart disease and things like that. So if you can influence, or diabetes, so if you can influence that somehow early, maybe changing diet, maybe including, motivating for exercise, maybe you can avoid some of those consequences of PCOS.
Yeah, which is kind of going into what I was going to ask you about, and you kind of started on it. So like, can you like prevent it or keep it from happening, or
PCOS itself? No, not really.
Can you do anything to kind of reduce the symptoms that you might have?
So that goes back to what to do about it, right? So once we decided that the patient has PCOS, then what are their symptoms? Usually we treat their symptoms more than the syndrome itself. So if they have irregular cycles or absent cycles or heavy periods, the first thing we would suggest is going on birth control pills, because those will regulate their cycles but also will help with the other symptoms like hair growth, because they will decrease the testosterone level in the bloodstream by increasing the levels of the molecule that will bind to testosterone. So it's kind of, it will work both ways for that. So so those would be the symptoms. If somebody has elevated blood sugar, so we know we would give them maybe an insulin resistance, maybe we'll give them medications to help with that, like sensitize their body to insulin more. So that would be what we would do, more like symptoms control and fixing that, instead of just preventing PCOS, because we can't really do that.
So like metformin, you're saying like if you have blood sugar issues type of stuff, is that
Yes.
what?
Yes.
Okay.
Mhm.
And then like hair growth, there's medicines that you'll give or a dermatologist helps them
Right.
with. In terms
So
of,
yeah, the birth control pills would be the first thing to start on, including then my help with acne as well, right? So so that might be just enough, or adding another medication like we can do. We can give spironolactone, which is actually a diuretic that's used in conjunction with other things to reduce the hair growth. However, once you have the hair growth, it's kind of hard to get rid of what you have, but you may prevent from more follicles coming through and having a heavier growth. So for reducing the hair growth itself, you may need more like a cosmetic procedures, like plucking
or lasers or
yes,
laser therapy, that kind of
yeah.
thing.
Mhm.
Yeah. How about for ladies who, you're talking about birth control. How about for ladies who want the opposite of birth control and they
Right.
want to get pregnant? How do you try to manage that with ladies?
So the problem with PCOS is that usually they have women have an ovulatory cycle, so they don't ovulate. So if you don't ovulate, you're not going to get pregnant. So the goal is to increase the ovulation rate. So we have medications we can use. We can use the Clomid or Letrozole. We can use any of those, but also in conjunction of other things. So if the person is overweight, let's say, or not even very overweight, even losing 5% of their body weight can help with the medication to work better.
Okay.
So it can help in the long run as well. So
Yeah.
exercise, diet, weight loss, and medications.
Okay.
Making sure the patient's healthy enough to get pregnant, right? So we don't want them to be diabetic uncontrolled or have a high blood pressure or something like that before even trying to get pregnant. We want to try to minimize their complications during pregnancy as well.
Sure. So like I'm gonna go a step further with you, and let's say, okay, a woman has been in the birth control method. They've taken birth control pills because they don't want to get pregnant. Then they go through the period of their life when they want to get pregnant, and they have the children that they'd like to have, hopefully. When they're done having children, is there a reason that women wouldn't just say, well, I'll have a hysterectomy and take out my ovaries as well as my uterus, and then my PCOS will go away?
I would say no.
So tell us about that. Why would that not fix that problem?
Because the uterus is just the end organ that can have problems with the PCOS. So taking the uterus out definitely don't have anything to do with preventing or
and the ovaries.
And the ovaries, if you have high testosterone, it's not only coming from the ovaries, it's coming from the adrenal glands because of other issues like the hyperinsulinemia or whatever.
Yeah.
I'm resistant to insulin. So taking ovaries will not help. The only surgery that we could do to help with an adjunct to medications to help ovulate is doing what we call like ovarian drilling, and that's really what it sounds, putting little holes in the ovary to help with ovulation. So that would be the only really surgery that's kind of adjunct to other therapies for PCOS. But removing things is it's not always good.
Yeah, I just kind of wanted to go down that path so folks can kind of hear that. It's bigger than just.
I'm not a fan of that.
I'm sure the women that are listening are glad to hear that.
Yeah.
I just want to. It's bigger than just your uterus and your ovaries in terms of the syndrome. Right. That's, I guess, the point I was hoping that we can make. Yeah. So, good. I think we've kind of covered the main things I wanted to about PCOS, and I hope that the women that are watching, I'm sure they're getting some good information from you, Dr. Vita Duden. Anything else you'd want to add about this topic for the ladies that you see in your
Uh,
practice?
there's more information on different websites, but our ACOG, Academy of Obstetrics and Gynecology, if you go on acog.org, they have a good resources for patients. You don't have to be a member of ACOG or anything like that. It's you can just Google it, go online, and get some answers. There's quite a lot of good things. I tried to look at it before today's interview, and I found some information that it's written like for patients to understand, not just for physicians.
Yeah.
So. Mhm.
Oh, thank you. Thanks, Rebecca and Dana. Yeah, so you see that in your screen there. So yeah, for folks who want to learn a little bit more about this, this is what you can do. And so just for the folks who are watching, Dr. Anabita Duden has been with us for, gosh, it seems like forever, but it's May.
Since May.
She's been a great addition to our medical staff. And
thank you.
She sees patients both here in Sterling as well as Dixon. So for those of you who are curious about where you stand, maybe in terms of ACOS or other, I'm sorry, PCO. I'm getting my acronyms mixed up. PCOS or other gynecological, or let's say you're pregnant. Dr. Bita Duden is the person that's going to be able to help take good care of you. So
I will try for sure.
All right. Dr. Bita Duden, thanks so much for taking the time, and hope you have a good rest of your day.
Okay, thank you very much.
All right, so great. What I want to do now is just do just a few shout outs before we sign out. And I know Rebecca has me teed up for a few things. So first of all, Ready Care has expanded hours, expanded service things that it can do x-rays now and stuff that we weren't able to do before. So you can see that there in terms of what's on in front of you. And I guess the thing that I would also mention is that I know we've had some more respiratory infections lately, a little bit of an uptick in terms of COVID in particular. So Ready Care is there to help you out if you have those type of symptoms, and they do a good job with getting folks as best they can in and out. And the hours now are more robust. So Ginger Lane is our respiratory therapist of ours, who also is the employee of the month. I was working with Ginger taking care of a patient this morning. She does great work, and I'm happy that Ginger is our employee of the month for September. And then, yeah, as Sherry alluded to, Laura and Charisse will be, I'll be interviewing them next month, talking about all the breast cancer support services we offer here at CGH. So I want to make sure that you're aware that that is up and coming. One other thing I would just briefly mention is pretty soon the updated COVID shot is going to be available. So, and I was just reading a little bit more about that today. Sounds like it's going to cover most of the variants, and even though this BA, I'm looking at my little thing here, the BA 2.86, even it's going to have it's going to cause some neutralizing variant antibodies for that one too. So I plan on getting it, but obviously these things are personal decisions that you all have to make in terms of whether or not you want to go forward with that vaccination. But it should be here, I'm going to say, what I'm reading is in the next couple of weeks, hopefully, but October at the latest. And so that's going to be available for folks. And particularly if you're at high risk for getting sick with COVID, I would encourage you to get one. Okay, well, I think that'll do it for this week, or this month, actually. I will sign out and look forward to having another interview and seeing you next month. Until then, thank you for watching.